Good day, fellow learners. Once again, this is your mentor, your fact check buddy, Ray Gapuz, joining you in this teaching and learning session. And we're supposed to answer one important question in which a lot of people have a misconception that maybe primarily since patients with colostomy would usually deal with the physiologic alterations that could result from the surgery, that the priority should be physiological complications. But that's not the case because there are recent studies that say otherwise. So this question is about colostomy. So overall, what is the most common complication of colostomy? Before we answer that question, allow me first to present to you our disclaimer and this invitation to join in this mission. Our goal is to provide free NCLEX RN application review to 100 nurses. We were able to do that last year, and we want to do it again this year. So to help us achieve this, just watch and finish the ads in our video. Thank you so much for doing that. Thank you in advance from the team of mentors from the Ray A. Gapuz system. So back to the question. Overall, what is the most common complication of colostomy? Now, as I've been saying a while back, some of us think that since colostomy involves surgery and that could potentially lead to alteration of the body structure, we think that the primary consideration should be the physiological reactions of the patient in relation to the surgery. But please take note that according to some studies done, overall common complications of colostomy include, take a look at the one with the highest percentage, psychosocial complications. So the primary concern, therefore, of the patient seems to be the alteration in body image. And the first question that we have to ask ourselves is, when can we say that the patient is beginning to fully accept the alteration in their body image that could have been brought about by the surgery involving the creation of colostomy? And one indicator could be when the patient is able to participate in the provision of care in terms of cleaning themselves related to their colostomy bag, or when they're able to take a look at the colostomy stoma. Those are beginning manifestations that the patient is slowly adjusting. Second would be at 34.5%, you have mucosal bleeding, but you have to pay particular attention to the fact that the mucosal lining of the stoma, when rubbed, really normally bleeds. So that's not a cause for alarm. And skin irritation, sometimes brought about by the pH of the contents of the intestines that could potentially erode the mucosal and lining and the skin around the stoma. And of course, peristomal hernia, 11% is the most common late complication. And the common manifestation of peristomal hernia is abdominal rigidity. So if a patient who have had colostomy and is already into the 4th, 5th, or 6th months after surgery, pay particular attention to the fact that for the first 3 months of surgery, the abdominal rigidity could be expected as the muscles of the abdomen adjusts to the surgery. However, if after 3 months, the patient still would have abdominal rigidity that would usually come about with nausea, vomiting, and bloating, then there could be a possibility that the patient could be having peristomal hernia. And of course, you have to report that to the healthcare provider. Now, let's talk about colostomy. What are the things that we have to know if we're studying this concept specifically for the NCLEX RN? Let's begin. So here are the pointers. If you're going to take a look at the picture that we have here, note that when the location of the colostomy is on the ascending column, meaning the right side of the abdomen, the feces would more likely be liquid. When it's in the transverse area, it's going to be paste-like, semi-solid, or oatmeal-like. Now, the transverse area is usually the site for double-barrel colostomy, in which you have a proximal and a distal stoma. Usually, the distal stoma would just have mucus, and the proximal stoma is the one that will have fecal matter. okay, in paste-like or oatmeal-like consistency. In sigmoid colostomy, it's usually located on the left side of the abdomen, specifically on the part of the descending colon. So in which case, the fecal matter that's going to come out here would be solid. So please note that the fecal discharge will not occur immediately after the creation of the colostomy. It would usually take 2 to 3 days before the first poo could occur, and that's expected. So the absence of fecal discharge in the first 2 to 3 days, meaning 48 to 72 hours after the creation of the colostomy, is not a cause for alarm or concern. And then the stools start to become formed around the 7th post-operative day, which simply means that the consistency may vary or may change during the first few days. And then what is important for the nurse to note is when there is difficulty inserting the irrigating tube into the colostomy stoma, that could simply mean that there could be adhesions that could have developed. And then the most important thing also for the nurse to remember is to irrigate the colostomy when the patient would have normally had a bowel movement. This is to align the colostomy irrigation time with their normal lifestyle. Now, some people will be asking, when is the best time to discard or to change the colostomy bag? Usually when it's 1/3 to 1/2 full, it is emptied, and usually it's changed every 24 hours. Now, it's also important to note that a normal colostomy stoma should be pinkish, moist, and a bit edematous. So there's no cause for alarm. What you need to pay particular attention to and refer to the healthcare provider is when the stoma becomes purplish or brownish. Okay? Okay. So what are some of the concerns that patients may have and the key points that we need to bear in mind when we're dealing with these concerns of patients? First, what should be the diet after surgery? So immediately after the creation of colostomy, clear liquid is usually given for 1 to 2 days. If the stoma looks moist, edematous, and there's usually no sensation, and it sometimes bleeds when it's rubbed, that is expected. It's not a cause for alarm. Absence of fecal discharge for the first 72 hours, once again, is expected. It's not a cause for alarm. The absence of control of bowel movement is also expected. And of course, the presence of gas, we have to address this because this could potentially cause bloating on the part of the patient. So we tell the patient to, in general, minimize or avoid vegetables, specifically beans, peas, broccoli, cabbage, onions, strong cheeses, and carbonated drinks, because this could potentially worsen gas formation. And then the other, so we have to limit onions, cabbage, garlic, fish, eggs, and fried foods. However, we can encourage them to eat butter and yogurt, as this may help neutralize the odor. And when there's an obstruction in the stoma, we'll have to tell the patient to minimize those that contain seeds like nuts, popcorn, corn, or apples, strawberries, and tomatoes, which when this would mix with fecal matter may potentially form a bolus that could potentially obstruct the stoma. Okay, so it's also important for us to note that when a patient has colostomy, the body image needs to be addressed. So let's use what we just discussed and talk about to answer a sample question. Here it goes. Here it goes. Which of the following statements on colostomy are true? Select all that apply. The stoma is normally moist. We talk about that. That is true. Food may affect the characteristics of stools. That is very, very true. Gas-forming foods needs to be avoided. Okay. The patient may engage in swimming. Yes, the patient with colostomy can engage in swimming. They can get pregnant. Okay. There's no need to worry about those hobbies if they would want to engage in swimming. However, contact sports should be minimized as it could potentially harm the patient, especially that the stoma is a little sensitive. So irrigation is best done according to the patient's preference. Yes, it should be aligned to the schedule of the patient's bowel movement, and the absence of discharge 4 hours after surgery needs to be reported to the provider. This should not be reported because for the first 2 to 3 days, we don't expect the patient to poo right away. So it usually comes after 2 to 3 days or even after 3 days. So we put an X. So I just hope you learned something new today, and may I ask you and invite you that for us to learn together, send in your request to my email, mentor.raygapuz@gmail.com. Please send me a message on what specific topic would you want me to cover in my future videos. So once again, this is your mentor Ray, your fact check buddy, saying a functional concept a day keeps your NCLEX RN fears away. If you love this video, please don't forget to subscribe, share, and hit the like and bell buttons so that you'll get notified when we upload, and we do that regularly on a weekly basis. Keep watch. We're going to have a new format of videos maybe next week. You'll be surprised. See you.